Hello, everyone. I'm waiting for everyone to just come on board here. The numbers are increasing. Just give it another few seconds. So welcome. I know people are still kind of joining the session, but I want to welcome everyone and thank you for joining Women's Way, Closing the Gender Wealth Gap, Black Women and Healthcare. I am Diane Corman-Levy, the Executive Director of Women's Way, and I'm delighted that all of you decided to spend the next 90 minutes with us. By choosing to be with us, when I know you're probably invited to lots of virtual meetings and events, you are choosing to join the movement to promote health equity and improve gender economic equity for all women. Today's forum is part of a year-long series whose purpose is to educate different stakeholders on the drivers of the gender wealth gap and actionable steps that each of us can take to close the gender wealth gap. Since October, we conducted 2 sessions. The first one was on strengthening the early childhood education sector, and the last one was investing in women-owned businesses. Today's session focuses on Black women in healthcare and why addressing racial and gender inequities in health and healthcare is important to the economic security of all women and their families. You will hear from hopefully four amazing panelists. We're still waiting for our 4th one, who will address the issue from a provider, from policy, from a health economist, and lived experience perspectives. You'll also have opportunities to ask questions to the speakers via the Q&A button located at the bottom of your screen, and we will do our best to address as many questions as possible. We also want to thank those who actually sent some questions when you registered. We are going to be answering some of those questions as well. We will also record the session and make it available for you to view again and for those who could not attend today's session. So before I introduce the panelists and the moderator, again, they're an amazing group of women. I am going to spend some time showing you some slides about the current economic state of women and why Women's Way is investing so many time and resources to closing the gender wealth gap. I first want to thank our sponsors, the session sponsors, who are the Philadelphia Commission for Women, Permit Capital Advisors, and Penn Medicine Women's Health. Their support really helps us make these type of sessions possible. So thank you for supporting this. So just briefly, Women's Way has been around for about 43 years, and we're the leading nonprofit organization dedicated to the advancement of women, girls, and gender equity. And we were the first umbrella funding federation in the United States specifically dedicated to women's issues. So we've been working on trying to advance the economic status of women for many, many years. And I just want to give an overview, so to give you some more context of the economic state of women. And I know we've been hearing a lot about this in the news with respect to COVID, but before COVID, the economic state of women was not great. Women and children were 73% of the poor nationally, and Philadelphia had the highest poverty rate at just above 25% among the 10 largest cities, and the largest demographic group living in poverty were women aged 25 to 34. And we also know when women are poor, children are poor, and over 37% of children were poor. These stats have not gotten better since COVID. In fact, they've gotten worse. And the health state of Black women. We've heard a lot about how COVID has been disproportionately impacting women, particularly Black and brown women. Well, before COVID, Black women were three to four times more likely to die from pregnancy-related complications, and 3 to 4 times more likely to suffer from a severe disability resulting from childbirth than white women. Another statistic is breast cancer death rate for Black women is 40% higher than that for non-Hispanic white women. So the racial in disparities in health were really significant before COVID. So what's happened since COVID? And again, it's not been good news, as we've heard in the news. Nationally now, 2.5 million of women have lost their jobs or dropped out of the workforce since COVID-19 hit. In September, 1 million Americans dropped out of the workforce, 80% were women. And then in December, about 140,000 Americans dropped out of the workforce, 100% were Black and Latino women. And part of this is women account for 74% of employment and high contact occupations that have really been disproportionately impacted by COVID. And a lot of them, majority of them are Black and brown women. There's also a lack of a childcare infrastructure or family forward workplace policies. A lot of women have dropped out of the workplace because they have to deal with taking care of children and other family members. And another disturbing statistic is many small business owners are women. In fact, the fastest growing entrepreneurs in our country are Black women. Yet 1 in 4 businesses close their doors by April 1st. And then the Philadelphia's unemployment rate increased from 5.9% to over 15%. A majority of them are women. So the economic state of women, unfortunately, has really worsened with the impact of COVID. And this is, when we talk about investing in women, we're talking about how it affects our regional and national economy. And this statement, if conditions for families do not improve, and if levels of maternal labor force participation in work hours experienced during the pandemic persist long-term, lost wages would amount to over $64 billion per year. So the impact of women dropping out of the workforce is not only affecting women and their families, it's affecting our regional and our national economy. So why build wealth? And wealth is really about building assets. It's not enough to just do anti-poverty work. We need to use an asset building framework to build wealth for women, because assets enable women to remain stable through financial emergencies. And we're witnessing this right now. When women do not have assets, when they don't have savings, and there's an emergency or something like COVID-19, it totally destabilizes women and their families. It helps them live with housing security, improve children's opportunities, take risks that result in better jobs or business startups, pursue higher education for themselves and their children, to retire safely and securely. That's another daunting statistic, because women are dropping out of the workforce, that they're not saving for their future and their retirement. And the poorest people in retirement are women. They also, assets allow them to pass on security to the next generation, and it helps them participate and shape political and social agendas. And I put it in bold, and maintain good wealth. So wealth, assets help women and their families maintain good health. So when you invest in women's wealth, you're actually investing in our region and nation. Women did comprise more than half of all workers. That is no longer true because of COVID-19. They now comprise less than 50% of the workers, because so many women are dropping out of the workforce. But nearly half of the mothers are primary breadwinners for their families. And like I said before, the fastest growing group of entrepreneurs are women of color. We also know that parental assets are the strongest predictors of children attending and graduating from college. And we always say, if you want to invest in children, invest in their mothers. And closing the gender wealth gap would result in an overall GDP gain of $4.3 trillion, or over $13,000 per person by 2025. So empowering women is really smart economics. What is the gender wealth gap? And again, this data was before COVID, and they're saying it's going to be even wider. At median, single white women own 32 cents on the dollar compared to single white men. Black and Latino women own less than a penny. And not only has it not improved for the past 50 years, it is now worsened because of COVID-19. So what are some of the causes? Well, women earn less than men, and this has to do with there's still not equal pay for equal work. Also occupational segregation, where occupations dominated by women are often undervalued and underpaid. Women are more likely to be denied mortgages, loans, or to be overcharged for them, even though they have a better record of paying back loans than men. They're more vulnerable to predatory lending. Women, by the way, the greatest population that's graduating from college are women, and particularly Black and brown women, yet they hold more debt. They hold 2/3 of all student debt, and they provide the majority of unpaid caregiving. And then I bolded the last two ones because we're going to be talking about the relationship between wealth and health and wealth. The impact of economic insecurity has tremendous impact on physical and mental health, and racial inequities with respect to access and quality of healthcare is another driver of the gender wealth gap. So research finds that those with more wealth have lower death rates, lower rates of chronic diseases, improved mental health, better ability to function in daily life, lower rates of smoking, obesity, and excessive alcohol use. So people with more wealth have better health overall. Another data point is when wealth and other socioeconomic factors are held constant or equalized, racial disparities in rates of death are much smaller. So investing in the wealth of women, you're investing in the health of women and their families. So what are we doing about this at Women's Way? Well, when I came on board there about 4 years ago, I said we have to deal with the economic insecurity of women because it really is the basis for so many things. So we started something called the Women's Economic Security Initiative in October 2017. And it's really to build a long-term systems level collaborative initiative centered around the vision that all women in the Philadelphia region attain financial well-being for themselves and their families. And we are very serious about all women. So this requires a long-term vision, long-term strategies, and a long-term investment. We're talking about fostering systems level learning and change among the stakeholders that we work with. And we work to break down silos across organizations and sectors because no one sector, no one organization can solve a complex problem like the women's economic insecurity. So since then, we've built what we call the WESI network. We have 82 active WESI members representing 54 organizations, and they span for-profit, nonprofit, philanthropic, and public sectors. And really important, we have women with lived experiences of economic insecurity at the table from the beginning, co-designing, co-creating solutions and strategies. We're going to be transitioning WESI to something called the Gender Wealth Institute, whose mission is really to close the gender wealth gap in the region by advancing research and practical solutions that build wealth for women who are economically insecure. And these sessions are part of this whole Gender Wealth Institute. So I know you're all here to listen to these amazing panelists, and I'd like to just introduce the panelists and the moderator, starting with Dr. Jade Shorter. Dr. Jade Shorter is a clinical assistant professor of OBGYN and specialist in complex family planning at Stanford University. When Dr. Shorter was at the University of Pennsylvania, she served as a member of the Department of OBGYN Health Equity Working Group, where she developed and implemented a formal health disparities lecture for third-year medical students during their OBGYN rotation. Her teaching and research interests include improving patients' experience with abortion and early pregnancy loss care and addressing disparities in health equity through a reproductive health policy lens. Marianne Fray is the Chief Executive Officer of Maternity Care Coalition, which is a 40-year-old community-based nonprofit organization serving pregnant and postpartum women and parenting families who live in communities impacted by structural racism throughout southeastern Pennsylvania. They are working towards a future, I love this future, where all parents can birth with dignity, parent with autonomy, and raise babies who are healthy, growing, and thriving. Driven by deep belief in equity, Marianne has dedicated her life to advocating for those who are marginalized. With decades of experience in both for-profit and non-for-profit organizations, Marianne had held senior management roles in healthcare, telecommunications, consulting, and publishing industries. She is also a respected collaborator with the national leaders focused on addressing the social determinants of health in communities impacted by structural racism. And I'm not sure if Dr. Jennifer Prah joined, but I'm going to announce it anyway, who she is, and I hope she did join us. She is the professor of health equity, economics, and policy, the former inaugural associate dean for global studies in the School of Social Policy and Practice, professor of medical ethics and health policy and scholar at the Center for Global Health at the Perelman School of Medicine, senior fellow at the Leonard Davis Institute for Health Economics and at the Center for Public Health Initiatives, all at the University of Pennsylvania. Dr. Ruger is the founder and director of the Health Equity and Policy Lab that conducts quantitative and qualitative research on the equity implications of health and social policies. And then Felicia Harris, a graduate from Howard University, has lived in New York City, the District of Columbia, and Philadelphia, where she worked with various businesses and nonprofit organizations to strengthen their impact across the region through organizational development, brand strategy, fundraising, and marketing. She currently is principal of HiTouch Enterprises, a full-service marketing and development firm that works with nonprofits and for-profit companies. She's also founder of Ginger Tea, a wellness brand that offers an array of organic teas and hand-poured candles. Felicia is founder and president of the Influencing Action Movement, chair emeritus of the Philadelphia Commission on Women, and a deacon at Salem Baptist Church. So those are our panelists, and we have an amazing moderator, Dr. Sarita Sonalkar. is Assistant Professor of OBGYN and Co-Director of the Fellowship in Family Planning at the Hospital of the University of Pennsylvania. She leads diversity, equity, and inclusion initiatives at Penn Medicine as co-founder and co-chair of the Department of OBGYN Health Equity Working Group. Her research interest spans broadly in family planning, including postpartum and post-abortion contraception, implementation of postpartum family planning, programmatic interventions, and HIV prevention in cisgender women. Dr. Sonalkar has been a consultant for the World Health Organization, Department of Reproductive Health and Research in Geneva, Switzerland. So thank you all, and I'm going to hand this over to Dr. Sonalkar. Thank you so much.
Thank you, Diane, for that introduction today, and to Women's Way for holding this important conversation. I wanted to start today just by posing an introductory question to all of the panelists and also defining income and wealth very explicitly. So income can come from a variety of sources, such as employment or disability benefits. Wealth, on the other hand, is defined as economic assets that are accumulated over time. Wealth also involves networks and the people around a person or family that may either require financial help or are able to provide financial help. And so both income and wealth disparities have been linked to health disparities. And I'd like to ask each of the panelists if you can give an example, either based on your work or your prior personal experiences, how the racial wealth gap, particularly in women, contributes to health disparities. And I thought I would start with Felicia.
Thank you for having me. So health, wealth, the gap. So I am personally a big advocate for helping women of color and families of color build generational wealth, which means, starting with the current generation and helping them to understand how money works and to make sure that they can build that type of lifestyle for themselves, whether it's through entrepreneurship, real estate ownership, or even savings and investing. And my husband and I, we teach our children that, we practice that with our children. And I can say personally for me, having had a family that did provide that structure for me, I have been blessed to, I guess be what you might consider almost second generational wealth, right? So we're building, my parents started, and now I'm doing it, and I'm doing it for my children. And because of that, and because of what I've been able to accomplish professionally, and also, have that mindset as well as those resources, unlike a lot of people who look like me don't have the same resources, I've been able to establish my own business, right? So I have control over my time. I can be there for my children, but also I can afford quality healthcare. Not everyone can do that. And, there was a time, where I wanted to explore to see what it would be like, if I could get a subsidy. I don't qualify for a subsidy, but I was blessed enough, between my income and my husband's income to afford quality healthcare, which has saved my life and my baby's life in numerous fronts. And I know I have an opportunity to share that a little later, but had I not had, the additional cash revenue to hire a doula, I probably wouldn't have had one, because it's not covered under, health care, under my health insurance. And I have pretty good health insurance. I pay almost $600 a month just for me and a baby. And that's being self-employed. And I cannot imagine how many women want to take that leap into entrepreneurship to build some type of, wealth for themselves and spend more time with their children. And they can't do that because they can't afford to leave a job that provides healthcare, because healthcare is just way too expensive. So there are so many direct links. I know other panels share their own personal testimonies, and how the two tie together and why it's so important. But that's my perspective and my take.
Thank you, Felicia. Marianne, I'd like your perspective on this too.
Thank you, Sarita. And I want to thank Women's Way for inviting me to participate in this discussion, and all the sponsors that made that possible. And for the fellow panelists, I just want to thank you for this platform. So Sarita, I would say that knowledge is a currency of freedom. So in order to start to bridge the gap in the disparities that absolutely exist, it starts with a kind of knowledge is different than data. And so we have to give ourselves time and opportunity to understand what is possible. Felicia just talked about the generational change that she's trying to impact. Her parents had choices they made that enabled her to do things. It takes knowledge, and then that knowledge propels us to have the will to work at our personal level, community level, and also at a systems change level. We're not going to be able to affect the type of change that's going to start to address these disparities until we are aware of them. And so at MCC, for example, that's something that we really work at. We work at the family level, the community level, the systems level. How can we encourage and disseminate information that can be then translated into knowledge that can catalyze action? Because, you know, as long as we're unaware and we are just kind of going through the motion, we're never going to be able to address these inequities. So I would say, you know, the answer to that question is knowledge is the currency of the change that we need to make.
Knowledge about health, knowledge about wealth, how would you
Both
specify?
because they're so interconnected, right? That's what Diane was talking about in her slides earlier. There's an inextricable connection between the social determinants of health, whether you can get to your appointments, all of those factors contribute to health. So you can't tease them apart there. So you have to understand how it works. And it doesn't take a PhD or anything like that. Like we need to understand how we can appropriate the information. And at MCC, we have advocates that partner with our clients. There are so many ways that we can arm ourselves. That's how we have made change across time. Is look at what happened with Stacey Abrams in Georgia. Like, people were organized. They had not, you know, there weren't people out there that had like playbooks. People basically armed themselves with knowledge and said, you have the power to act and affect change. That's why I guess I start with we need to make ourselves aware. I hope that answers your question.
I think it does. I can't wait to hear more about Maternity Care Coalition and all the work that they do, but I am going to move on to Dr. Shorter. I would love to hear your perspective as well.
Thank you, and it's such an honor to be here amongst amazing panelists, and thank you, Diane, for having me as well. So I view this kind of question from, I like, Marianne, how you kind of mentioned the different levels to look at this issue from. So there's like a systems level, and then, you know, for me as a provider, looking at kind of the doctor-patient relationship, I think this plays a huge role there. You know, systems levels has been talked about. You know, we focus on insurance, cost of healthcare, which is, you know, its own issue and has its own problems. But essentially, our system promotes financial wealth as a means to adequate physical and mental health. And again, that's most obvious through how our insurance works in this country. You know, we know on a larger scale that lack of financial wealth leads to poor health overall, as Diane had listed in her slides earlier. We have higher rates of chronic disease, less opportunities to practice preventative care. Wealth gap can lead to poor nutrition, increased obesity rates. It can cause severe mental illness among patients, and that further exacerbates poor physical health. But as a provider in the day-to-day basis for what I kind of experience with my patients, I really see kind of the downstream effects of this, where there's a lot of major roadblocks essentially to receiving healthcare in general, and also prevents patients from receiving equitable and adequate care from their individual providers, unfortunately. You know, there's difficulty that patients face with transportation, childcare, challenges navigating the healthcare system, which is hard for all of us, even if you are in the system. This creates frustration for both patients and providers. When patients don't show for their visits, don't pick up their prescriptions, it kind of perpetuates this bias and stereotypes about certain patient populations, unfortunately, and then providers assume that their patients don't care about their health. Instead of asking the question, why are they not showing for their appointments? Why didn't they not take their medication? And I think it, again, just makes everyone frustrated. You know, physicians are tired. They're not looking into why this is happening or how we can fix it. And there's no creativity about how to fix these issues. And no one's asking the patients what the issues are and asking their opinions for how to fix it. So I think that's you know, something that I focus on as a provider, is really listening to my patients and figuring out how can I provide the same safe healthcare to them in the face of all of these struggles, which has just further been exacerbated by COVID. You know, people are losing their jobs. They, you know, they're you know, they have lack of insurance, and so we really have to be creative in how we provide, you know, care to all of our patients.
Thanks, Jade. That's such a compassionate and really important way of looking at taking care of patients. I really appreciate that perspective. Jennifer.
Thank you. Well, thank you for having me. And I just wanted to add to what the prior speakers have said, because I agree with their perspectives, and also to Diane's very thorough presentation of statistics, which I think really lay out the problem. But I do want to emphasize that across virtually every single health condition, we see differences and disparities on almost every health indicator in terms of excessive morbidity and excessive mortality among Black, Indigenous, people of color, women compared to white women. It's just, and white men, it's just almost every single indicator. So this is a comprehensive problem. I'm a social scientist, so I'm stepping back a little bit. And so I think it requires a comprehensive solution. And what does that look like? That looks like a broader interdisciplinary exercise of really trying to understand the underlying frameworks of social, cultural, environmental, economic, and political explanation. So we've heard a little bit recently in terms of environmental justice. The current administration has been looking into that or highlighting that, holding that up. If, for example, the disparities that we've seen that have come through from COVID, both in terms of the outcomes, sadly, greater rates of death, infection, risk, testing, now vaccination. So it is not a coincidence that we see such broad sweeping patterns. So we need to get deeper and understand what kinds of theoretical frameworks are undergirding this. And I think that it even goes deeper than that. And I would like to suggest that we need to look at the underlying set of beliefs and values that we have in this country and try to understand why it is that there's a differential value on the health and well-being of certain parts of our population as compared to others. And when we start interrogating that hierarchy, we may be able to make a little more progress in creating a more equal set of values, which then we will embed, I hope, in more egalitarian structures, institutions, and sets of relationships with each other.
Thank you, Jennifer. This actually connects well to my next question, which is actually for Felicia. Implicit biases have been thought of as shortcuts in the way that we think about people. We know that we all carry biases and that these can worsen in stressful situations, particularly in acute stressful situations like when we're taking care of patients. Can you talk about some of your salient experiences with the healthcare system that might illustrate some of the biases that you've experienced from providers as a patient?
Yes. So In 2015, I was 29 years old, and I, at the time, worked at the Urban Affairs Coalition, and I worked on the 7th floor. It was very hot. It was a hot day in September, and the elevators were broke, and I had to walk up the steps. And when I got to the top, I could barely catch my breath. That went on for almost an hour before my boss at the time urged me to go to the emergency room. And while I was there for hours. I was there for hours. And I had an EKG done, never had an EKG done before. And I found out, after she called down to the president, she knew the president of the hospital, and she asked if someone could check on me because I had been there for a very long time. And so that relationship definitely helped. I think that they were more thorough because of the phone call that came down from the president of the hospital. And I actually was originally discharged. They gave me some ibuprofen, discharged me because they couldn't figure out what was wrong. And then I was 2 blocks away. A nurse came chasing after me. I had to go back to the hospital. I guess someone finally followed up, and they realized that the EKG in my file was wrong. It was someone else's. And so when they looked at it, it turns out I had a heart defect that I apparently was born with. And I'm 29. I was 29 years old at the time. So it's like, how do you go 29 years, in life with a heart defect? It was Wolff Parkinson's White syndrome that could cause sudden death. And it had gotten progressively worse over those 29 years that I had to have an emergency operation. And when I met with my cardiologist at the time, an Indian man, he looked me square in the eye and said, I'm going to be very blunt with you. I'm looking at your medical history, your family medical history, and you should have had an EKG years ago. There's no reason you should not have had one, given all the symptoms that, you had over the years. And he's like, I'm going to say this, but it's true, because you're a Black woman, that's probably why no one stopped to give you an EKG. I had been diagnosed with anxiety, high functioning anxiety, being, emotional disorders, but no one ever wanted to check my heart to see if something was really wrong, because as Black women, I guess we're stereotyped to be very emotional, instead of us, something really being wrong, something that could have cost me my life. So, that was my first, real experience with having, been discriminated against because I was a Black woman. And, again, thank God that I, worked for someone who had the relationships and the connections to make a phone call and for them to, do their due diligence like they should have done anyway, regardless of my race or my gender. So I know that one is a lot, right? And most recently, I'm, a proud mother of a 1-year-old, my firstborn, and I am the past chair of the Philadelphia Commission for Women. And under my tenure, we began to work with, Women's Way Maternity Care Coalition to raise awareness around maternal mortality. Black women are, we're marginalized, and we are dying at a much higher rate than any other race during childbirth. Either during birth, after birth, our babies are dying because we aren't receiving the proper care. People aren't listening to us when we think that something's wrong. A lot of times we don't know the right questions to ask. I mean, any mother may not know the right questions to ask, but people aren't asking us the questions either. And through our advocacy campaign over the years, I learned that getting a doula could save your life, especially as a Black woman. You have a higher chance to survive through the labor experience and postpartum if you have a doula. And so I made it, a priority to get a doula. No one in my family actually knew what a doula was. I didn't know what a doula was until I, was part of the Women's Commission, and we did this research and we partnered with organizations to provide those resources. And I was 37 weeks pregnant when I developed preeclampsia, and it was only caught by my doula. My doctor read my blood pressure, said it was slightly high, asked for me to come back in a few days. My doula asked more questions. She wanted to know if I had, any sharp pains in my side, how was my eating? Was I fatigued? Were my ankles swollen? The questions that my doctor did not ask me. And because she, was thorough and asked those questions, she had me go back to the hospital a few hours later. And by then my blood pressure was through the roof and I had to be induced right away. And had I waited until Friday, I may not have lived to see Friday, me or my baby. And again, it's because, I was equipped with that education. I knew that I needed to get a doula. But the lack and the bias there is, I don't know. If I was a white woman, would they have asked me more questions instead of just shrugging it off, saying, oh, her blood pressure is a little high? I don't know if it was a bias that maybe I eat a lot of salty foods. I don't know. But what I do know is that, I had the resources and I was equipped with the education and the support that was given to me, but not everyone is. And there are a lot of women, Black women, that are not here today, and their babies aren't here today because they fell victim to someone else's bias.
Felicia, I really want to thank you for sharing these personal stories with us. It is really a gift, and it's not something that you had to do. And I really am moved by what you've told us. Thank you so much. And I'm so sorry that you had to experience those things. I'm so glad that you are with us today. I'd like to direct my next question to Marianne, and maybe you'll be able to address some of what Felicia talked to us about. Health equity means that everyone has a fair and just opportunity to be healthier, which is what the Maternity Care Coalition is dedicated to. And it involves trying to understand and give people what they need to enjoy full and healthy lives. Equality, in contrast, aims to ensure that everyone gets the same things. And although equality is an end goal that aims to promote fairness and justice, it really can only work if everyone starts from the same place and needs the same things. So what are some ways in which Black women historically have been structurally and systematically impeded from receiving equitable health care? And what are some of the things that we can do that can provide equitable health care today?
Great question. And I want to echo, Sarita, your comments to Felicia about, it really is unfortunate. Well, unfortunate doesn't seem to be the right way to describe it. It sucks, right? But to answer your question, you're right. Equality and equity are they're just different because we're not starting all at the same place. And in the story that Felicia shared, I could think of, and we didn't rehearse all this, by the way, for all the participants. This is coming from our heart. Felicia, you said exactly what I was talking about. Knowledge is the currency, right? That's all I could think was, if you didn't have Charmaine advocating for you, if she didn't have the relationship, if she didn't have the information, you might not be here, right? So we've got to make sure that we arm ourselves. That's one thing. And that starts to talk to the equity piece. So, I looked at the list. I'm one of those typical panelists. I went down a participant list and I saw that I have a colleague on who's responsible for our doula program. Katya's on. I think I saw a couple of other people. And I was so glad, Felicia, that you made comment about the importance of having a labor support. That's what a doula does. And those types of helps are what MCC does in order to ensure that our families live and can thrive. So your question was what are some examples, right? Or what can we do? We can arm ourselves. I would say MCC is here for you. And we have a commitment to helping parents in Southeast Pennsylvania birth with dignity. What that means is that you know yourself and you know your body better than anybody else. That does not discount the expertise of a medical provider, but you have the self-determination to make decisions that will help you thrive. That's what MCC does. We want you to birth with dignity, parent with autonomy. What does that mean? It means that you are your own best advocate. You get the information. Nobody can tell you, oh, Felicia, you need to go home because your blood pressure. No. Serena Williams, she had all the money in the world, right? And she said, listen, something's wrong here. But no one listened to her. So that's what we're committed to. You need to be able to express what you need to do in order to stay alive. And then raising babies that are healthy, growing, and thriving means that we have a system that sets us up for success. And I really like a lot of the things that Jennifer talked about in her introduction. There really are some systemic problems that exist that we have some, there's a Omnibus Act that has 12 bills that has been introduced that I really want each of us to take a look at and call our Congress people and make sure that they will vote for that. And it's dropped into the chat box so you can see what it's all about. But that's a way that from a systems level, we can start to advocate to make sure that we have representation, we have support from a legislative standpoint. And then I also think that there's a CDC campaign that says "Hear Her." That also is in the link. And that is a great way to make people aware that we should listen when a Felicia or a, or I have my story. If you have a chance to read the blog that I wrote for Women's Way, I needed somebody when I was younger and I had a teenage pregnancy. I wish I had known Maternity Care Coalition then. I wish that there was somebody that could have said, Marianne, this is not right, what's going on. But I didn't have that advocacy. I didn't have a Charmaine that you had, Felicia. My parents were well, first of all, they weren't even happy that I was pregnant. So let's not even talk about that. But what I'm saying is you need to have information and you need support, and we're there to do it. And if you have any questions, I encourage you to contact us or Women's Way. There's so many resources. Jovita's on the line. There are all these different resources that are available to us so that we can stay alive and we can thrive. So I hope that, and read my blog, and hopefully you can ask me questions about that. That's another example. I don't know if I want to talk about it now. I might break down and cry, and that might not look too professional. So, but I hope that answers your question, and the resources are in the chat.
Thank you, Marianne.
Mm-hmm.
And thank you for all the work that you do with Maternity Care Coalition. Dr. Shorter, I have a question for you. So data from the AAMC, or the Association of American Medical Colleges, shows that only about 5% of the currently active physician workforce identifies as Black. I'm interested in how you see workforce diversity affecting healthcare and health to help patients like Felicia.
Thank you for that question. I just also want to reiterate to Felicia, thank you so much for sharing your experience. I'm so sorry that you had to go through that. And unfortunately, it's a common thing for many of us, many patients of color who have seen that similar situations happen, and or family members go through similar things. So, this is really important to me, obviously, as a provider. I think diversifying the workforce doesn't completely solve the problem, obviously, but it's a start. I think we need people working on the inside of the system who can start to dismantle this long history of systemic racism in medicine. We can't forget that, we can't ignore it, and we need to address it. And so we need people who have had shared experiences like Felicia and understand what it means to be a patient of color in a predominantly white healthcare system. Many providers of color, myself, have experienced themselves or through a family member for how bias and racism in medicine can affect the quality of care that you receive. We have family members or ourselves mistrust the medical system, rightfully so, especially in OBGYN. There's a long history of experimentation and racism in our field that still exists today. And patients know this. This is being talked about. It's no longer swept under the rug or kept a secret. And so I really feel it's important for our patients to have doctors and staff that look like them, that can help first just address this issue of mistrust of the system. I've had so many patient encounters, especially at my current institution, where my Black patients have expressed relief when seeing me walk into their exam room, or purposely sought me out or researched online for hours to find a provider who looked like them so that they would potentially get fair care. There's this sense of calm and shared understanding when I walk into a room and I have a patient of color sitting there, that I'm going to listen to them, not judge them, and hopefully treat them, based off of their experiences and them as a person. I think on a larger scale, diversity among providers and staff can also help change systems and policies. You can't have just one group of people coming up with, our algorithms or protocols or rules. They only have one experience to provide input on, and you need people from different backgrounds to share their experiences and perspectives on how we should run our hospitals, essentially. And so we need more diversity in research also, and we need people who are asking the right questions, who are performing the research, who are engaging the community, and not just focused on the academic research that has been raised in systemic racism for so long. So those are the main things that I think of, that diversifying the workforce could really help make changes.
Dr. Shorter, you and I are both family planning physicians, and you alluded to some of the systemic racism in our history and really the sordid history of racism in medicine. And I was wondering if you could speak to that a little bit more, maybe give examples of how Black women have been treated truly unjustly, particularly from a family planning perspective related to contraception.
Yes, definitely. Unfortunately, there's a long history in our field. I think some of the classic examples are forced sterilization among Black women, all women, honestly, within history, but particularly among Black women, Hispanic women, and having patients essentially not being counseled appropriately, or actually being just having these procedures performed without their knowledge, and told that something else is being done. So, hysterectomy is being done when patients think that they're having another type of procedure, and just, the culture and society thinking that it's dangerous for Black women to procreate, and essentially trying to decrease the population. Contraception, and kind of forcing or coercing women to get long-acting contraception, when maybe that's not the best form of birth control for them, or even what they want, but basically trying to prevent Black births. And that is solely rooted in racism, essentially. And these are things that my mom talks about, my grandmother talks about. I mean, it's talked about and passed on within generations in our families. And as a provider who does that care and is trying to change the system, it's really hard. You just have to acknowledge it. You have to say, you have to know that history. I think it's really important.
And then I think on the flip side of it, we have the Hyde Amendment, which prevents public funding for abortion, and disproportionately affects Black women and women of color. And really there's structural elements in place that are controlling Black women's bodies, and it really is extremely disruptive to the trust that Black women feel when they're seeing us as patients. And I'm sorry to go a little bit off script here, but I wonder if, Felicia, you can talk to what trust means to you in your interactions with providers.
Yeah, so ever since that health scare I had with my heart, having trust now, it's like the basis for everything when it comes to me choosing a provider. Honesty, transparency, providers making an effort to want to understand and know me, and not just look at me as another patient, but to look at me as, who is Felicia? How can I understand Felicia to better help her? I went from, having a white male doctor who prescribed me medicine for everything without, I would be in and out in 10 minutes, to now I have African-American female doctor, and my doctor's appointments may last almost an hour, because we're talking not just girl talk, but we're talking about what's going on in my life, so that she can better understand my lifestyle, so that she can provide that best possible care for me. And so that is also relationship building, right? When you're in and out in 5 and 10 minutes, it's how can you build a relationship with a doctor in, you know, a 5-minute visit every 6 months? So the big part of the trust also comes from the doctor wanting to build an authentic relationship with you to show that they care. And when they learn to care for you, they can better care for you. And so I look for that in providers. Even for my daughter, I sought out a doctor that looked like her. I was very intentional about that because of the experience that I had. Now, I do have a white female OBGYN, and you know, separate from my birthing doctor, who's awesome. I've been with her for years. And again, we're in there 20, 30 minutes having great conversation about, you know, my health and my life so that she could better treat me. And I was sad that she couldn't be there, you know, for the delivery of my baby. Maybe it would have made a little bit of a difference there. So I don't necessarily think that it's the race of the doctor, but when you've gone through these traumatic experiences and the people that care for you the best are the people that look like you, then, you know, you start to have your own bias. And until we can start building authentic relationships with each other, it needs to be a shared two-way relationship. Until we can do that and build that foundation of trust, the system is going to be broken and people are going to continue to have these biases both ways.
Thank you, Felicia. I think that is such a good point about relationship building. Jennifer, I'd like to ask you about some broader scale health policies. So the ACA was a step forward in allowing greater access to healthcare. What do you think has improved since the passage of the ACA and what still needs to be done?
Thank you. I too want to highlight Felicia's comments and how helpful they are to understanding how to move forward in a much more effective and progressive capacity. The ACA was our really latest major health policy project of the last 50 years. We had Medicare and Medicaid, of course, and then we finally did get major health reform in the Affordable Care Act, and some call it Obamacare. It was helpful in many respects. It did expand health insurance coverage to many Americans, and it did expand coverage to African Americans by about 2.8 million people. However, it's not a perfect law, and it was overlaid on not a perfect health system. So there are, imperfections laid on other imperfections. So let me unpack that a little bit. The first thing is that even with the Affordable Care Act, unfortunately, we see disparities remain in health insurance coverage. And I'm not even talking about underinsurance, which is when people might have some form of coverage, but they don't cover the things that they actually need. And I'll talk in a minute about medical debt. And that's when we see that being a huge problem. So we have differences in uninsurance rates among African Americans and white Americans. That's about a twofold difference. And we also see a difference in the amount of what we call out-of-pocket payments, or just the amount that people have to pay out of their pocket, whether they have insurance or not. A difference among African American families and households as compared to white households. African Americans, even now with the Affordable Care Act, are spending on average 20% of their household income on healthcare. And that's a lot. That's a large percentage. That means that there are other things that they are unable to spend that money on. It can also lead to an escalation into medical debt. And I'm going to talk about that in 1 minute. So that's still a major issue. The last thing I want to say about the Affordable Care Act, there's more to say, but is that there was an effort to support a Medicaid expansion at the state level, which we know from studies has improved coverage. and yet we have resistance among certain states, particularly in certain parts of this country, that did not expand Medicaid, which means they didn't expand health insurance to significant parts of the population. And so that's an unfortunate part of the Affordable Care Act expansions, because it wasn't equal across the entire population and across the entire country. So we have now these additional disparities. I also want to say that even though, again, it did expand coverage and it did help with the cost of healthcare, we still see medical debt being a huge problem for American families, in particular African-American families. So we see, again, disparities in past due medical debt for Black families as compared to white families. And you see almost a 10% difference there in past due medical debt, which is more for Black families. We also see the insurance rate is lower for Black families than for white families, and the uninsurance rate. So this medical debt then continues to augment and add, on top of each other. And we can see also, as we heard earlier from Diane's statistics, that we're seeing much more rapid expansion in entrepreneurship among Black women, which is exciting, although COVID put a real stop on that. And then, of course, we know that small businesses are very susceptible to the high cost of healthcare for themselves and their employees, and also and the financial implications of excessive healthcare costs. So this is just a really big problem. And so we need to do more and we need to do better. And I do think that the financial reallocation of resources is the heart of it. And the last thing I want to say is I want to share with you a major, I think, cause of our problem, which is we obviously need to any kind of an equitable, and here's equity, not equal, equitable health insurance system transfers resources across the population, from the wealthier and the more privileged to those who need it. And it is done in a equitable and an efficient capacity. Yet in this country, what we have is we have such stark inequalities and such concentrations of wealth that there's been a obstacle to that. And one statistic that I think is helpful is that the 400 richest American billionaires in the United States have more total wealth than all 10 million Black American households combined. So if we look at that, because to get to a more equitable health insurance system, which hopefully will get us to a more equitable health care system, we need to reallocate resources. And that statistic just helps us. So it's only one that can help us understand how the concentration of wealth in this country is related to the inequities that we are seeing in our policies in our healthcare system.
Thank you, Jennifer. So we're coming on 5 o'clock, and I'd like to address some questions from the attendees. And thank you. I know some of you submitted your questions ahead of time while you registered. And so we are going to address some of those questions first. And then if we get some questions in the chat, we may hopefully be able to get to some of them as well. So actually my first question that I have from the audience is, and I'll let the panelists take the question. Whoever would like to take the question can do so. What role do inequalities in the local space, such as the city, the town, the state, have in relation to access to healthcare for women? Maybe Marianne, would you like to answer that?
Can you repeat the question? Can you repeat the question?
What role do inequalities in the local space, such as the city, the town, the state, have in relation to access to healthcare for women?
Well, when Jennifer was talking about the ACA and how there's certain states, I mean, ACA or Medicaid, where a lot of poor and low-income folks are either insured or uninsured, they're impacted by whether, and Medicaid is funded by both the state and federal. So from a local standpoint, there are people that, families that are unable to really take advantage of care because they don't have either the access to getting care, and locally there's not a lot that they can do. The city is already under doesn't have a lot of money based upon what's happening post COVID, but the state basically gives the funds for Medicaid, which is how poor people get access to care. But there's a lot of hurdles to getting to that care. Can they get transportation there? If it's a birthing person, if they have a 6-week, if they only have coverage for 6 months and they need care after that, there's not coverage for that. What can the local do? It's not a lot that the local government can do to really support families that way. But I would ask Jennifer if there are other ways that locally there's some way of helping families to do that. But it's really, really hard. And I think what we need is universal health care. I mean, it's so difficult to try and navigate all these other ways of trying to cobble together. There should not be all of these factors involved to get care. It's not a privilege. We absolutely need to have care without a lot of, bells and whistles that you have to, or hoops you have to jump through. But I'm curious, Jennifer, if there's something that I've missed from a local perspective. No? Okay.
I agree with you. I agree with you completely, Marianne. I think we need universal health coverage, and I think we need it across this country, and it needs to be equitable.
Yeah, I just don't see, I don't see how else. And Dr. Shorter, from your perspective, can you, and I don't mean to take your place, Sarita, but I'm just curious what Dr. Shorter was thinking.
No, I agree. Everything that you guys said. I see it on a day-to-day basis. Universal health coverage would solve so many problems for even just which clinics patients can access within the same department is, dependent sometimes on insurance coverage, and which is just ridiculous for the same exact care that they need to receive. They should not be in different locations based off of their insurance. It's
Felicia, do you have anything to add?
Yeah, so I'm thinking also about, local laws and regulations around employers and what employers, I guess what they have set in place for their employees as far as not just healthcare, but time off. And paid time off, sick leave, because you can work at a company and have really good health care, but if you don't have that paid time off, or however that may work, like, can you take off to go to the doctor? Can you take off to take your children to the doctor? Can you stay home? Can you afford to do that if you have bills to pay? And so then you also have to think about, the minimum wage. Is it a living minimum wage in place to make sure that I can do those things as well? And so when I think about the inequalities at the local level, I'm really thinking about, I guess, around employment and the things that govern that, and the policies that each city and state have in place to protect not only individuals of color, but women, so that they won't lose their jobs, so that they can afford to take the time off to take care of themselves and their children.
Diane.
That's a good point.
Mm-hmm. Thank you, Felicia. Those really important points.
Yeah, I just wanted to add to what Felicia said. Some of the key drivers for the gender and racial wealth gap are what we say occupational segregation, where a lot of women are in careers that, one, don't have livable wages and do not have paid family, paid sick leave, or benefits. And they're the primary caregiver on top of that. So you have to make a decision of, I have to take my child to the doctor, not just myself. And I don't even have I can't even take a day off. If I do, I lose income. Right? So it's, and I'm just going to say something here, because I have to say that the elephant in the room is we have a system built on white supremacy in this country. That is the root of all of this, which has created a hierarchy of value, which Jennifer said, that white people are valued, that they are deserving of more resources, and that Black and brown people, particularly Black, are deserving of less resources. And it was set up that way from the beginning to put white people, particularly white men, at an advantage economically. And that's why we have this economic pyramid where the top 10% own like 80% of the wealth now in this country. And so we have to deal with that as a country and as a system. And white people really have to look at that. And so those biases are coming from that system of our economic system based on a system of white supremacy. And I just had to bring that up because that is just everything. It's affecting, that if we don't address that, we're never going to get to a point of equity in this country.
Diane, I think that's really important what you just said. And it's sometimes we dance around things, but you're absolutely right. It is a system that was designed in that way. And in order to really, there's that whole debate going on about reparation, like it's real, right? It's really real because the only way to get to someplace better is you got to acknowledge that it was designed from the beginning to be inequitable. So thank you for saying that.
There are so many examples from history that really show how the gender wealth gap and the racial wealth gap have evolved. And I don't know if any of you would like to speak to some of those examples, redlining policies, differences in how the GI Bill, disparities in how the GI Bill were distributed. I don't know if anyone would like to speak to some of that. Jennifer, maybe, do you want to speak to that?
Well, I want to highlight environmental injustice. Because that's something that people can get their heads around. That the fact that we have major environmental risks that are in neighborhoods that are predominantly non-white neighborhoods. That's number one. Number two is disinvestment in neighborhoods. There's plenty of, I'm a social scientist, there's lots of research that the social determinants of health, and we've been talking a lot about healthcare and the healthcare system and health insurance, but we know that the social determinants of health are very strongly determinative of morbidity, mortality, well-being, and certainly flourishing, which is the area that we work in our lab. And so, we started this whole conversation with an asset-based orientation and building assets. And so going from disinvestment, which is true, it has been based on legislation and policies and structures and institutions, and the racism and the patriarchy that have been the foundation of this country and many parts of the world. And also the kinds of approaches to the market vis-a-vis governance and government, and what kinds of orientations we're interested in. So there's work being done on humane capitalism and you're just trying to figure out a different orientation, because it's very clear that what we have now isn't working. Many people are not at the starting line, and Marianne noted reparations, and just trying to figure out how because we have problems that need to be solved. But the good news is we have a lot of capacity in our populations if we listen to people's experiences and try to address it.
I just wanted to build on real quick something that Jennifer said around, and it's around the redlining. And when I was writing my blog, it really was stimulated by a picture that I saw online just on Sunday of the neighborhood that I grew up in. And now they're building a multi-million-dollar, multi-use facility right around it. And where I grew up is where poor people live, but we have created a community where we support one another. And I'm just astounded. The only question I could ask is, where are those families going to go? And I'd like to actually have that conversation, like, where do people go when we make these decisions based upon economics? What happens to the individual? And then what's the impact of that over time on our bodies and our families? It's like you never can catch up. And so I really I'd love to hear from anybody, like, where, if where your neighborhoods are, where do people go? How do we deal with that? It's a burden that is killing us. And I don't have any easy answers, because I know that there's economics around. I don't have any easy answers, but I tell you one thing. I know that there are people on this call and at Women's Way and at the organizations that we represent, that if collectively we get together, we will make a difference. That's the only way we can keep on getting up every day, right?
There were some questions from the audience about implicit bias and implicit bias training. So one of the questions that was submitted was, is anti-racism and implicit bias training mandatory for healthcare professionals working with Black mothers in any institution that you know of? And I'm going to ask Dr. Shorter this question.
Yes, thank you for your question, whoever asked it. It's unfortunately not mandatory amongst all specialties, or I think it's talked about more now that, again, it's not swept under the rug as much. Patients are bringing this issue up. It's in the news. It's it's everywhere. It's on TV. So it's definitely kind of the first thing I feel like we get an email about is we're going to implement implicit bias training as the solution. I would say more of implicit bias training, less of anti-racism training. I would say that's more evolved and nuanced, and definitely not at many institutions that I know of. I know at the University of Pennsylvania, before I left, we had started to kind of implement that training within OBGYN department. I don't think it was quite mandatory, but heavily encouraged among our providers, but definitely not where I am currently, and with talking to colleagues, not there as well. It's an option, but not mandatory, unfortunately.
I will say at the University of Pennsylvania, the implicit bias training has become mandatory across all departments, and so that has changed. I think there was another question in the chat as to whether implicit bias training is truly effective, and I don't think that we have good evidence on that yet, but it is at least a first step in increasing the awareness of the problem and how bias influences the care that providers give. I wanted to ask, one of the questions was, what are some resources to help Black women elevate their careers in healthcare? And I'm going to ask Dr. Shorter again. I'm sorry to put you on the spot one more time. If you have any resources that can help those that are interested in healthcare.
I would say, unfortunately, there aren't many resources is the problem. I would say mentorship is the first step. Again, goes along with diversifying the workforce, having more diverse providers and leadership roles. It's just good examples and role models for our young trainees and students kind of looking for someone to follow in their footsteps. So, by word of mouth or searching online or things like that, kind of looking for a mentor that can kind of help guide you through this very complex, challenging system. And then also, I think promotion as well among just any person of color essentially in leadership roles is really important. I think that has definitely played a role in how successful I've been so far, and people just recognizing who you are and that you have maybe lack of resources or the privilege of just knowing people in the system or having family members to kind of help elevate you, but having our allies essentially see us and kind of help us work through the system as well is really, really important.
Yeah,
Oh, I'm sorry.
I was going to build on what Dr. Shorter was saying is that, you know, I have a sister and a son who are medical providers, and they often talked about the importance of, you know, in businesses you have employee resource groups or ERGs or BRGs, but that in medical school and their medical settings, they're looking for community to assist with their decision making. My son is in the military and he's a physician, a family doc, and he will network with other, you know, physicians and of color, and they have like their own little ERG. But it works in business. It works in any setting. You kind of convene a group that are your peeps, right? And then that's how you help kind of figure out, this is how I'm feeling, and we help one. It's a village. It's what we did back in our family or in other settings, is that we help one another. And I think that's probably one of the better ways to try and figure out how to navigate in a system that is not designed to support you all the time or in many ways. It looks like Felicia has something.
Oh.
Go ahead, Felicia.
Oh, I just put it in the chat before.
Oh.
I didn't want to interrupt anybody while they were talking. And I was like, let me type it while.
No, you go first. You can
Go ahead.
I kind of wanted to go back to about the implicit bias training. And I actually put it all in the chat. What I was feeling is that's a great start, but that it literally is just a start. That's one step. When you talk about equitable resources and everyone receiving, you know, equal quality of care, that means understanding the demographics and the populations that you're treating and that you're providing for and you're caring for. And you can't, and I think part of it is ignorance to think that, okay, I'm not racist, I don't have an implicit bias because I treat all my patients the same. That's like saying color doesn't matter.
Yeah.
Like, you have to understand what their food choices are. There are people who live in food deserts. They don't shop at Whole Foods. They can't afford to shop at Whole Foods. They can't even get to a Whole Foods. You have to understand what access they have to food choices, quality of daycare, their housing situations. And if you don't take that time to understand those circumstances of the people that you're treating, you'll never be able to provide the same quality of care, not the exact kind of care, but quality of care, because the people that you relate most to, you probably treat them the best. They probably get the best of your care because you understand them, because you may feel like you are like them. But if you don't understand that population, and I'm not saying that you can't, because you can, you need to understand them. You need to understand what their circumstances are so that you can better treat them.
Yeah, I think, Felicia, that's so important. It really speaks to the idea of cultural humility. I think previously in medicine, we had this idea of cultural competency, which sort of assumes that you can understand different cultures, but the truth is you can't, because culture is very individual. And even when you may see somebody who does have the same skin color as you, that doesn't necessarily mean that they really come from the same culture as you, or that they're the same as you. And so I think, you know, we as providers need to approach every encounter very open and from a very humble place, with an idea that we are there to learn. And I think that that probably allows us to reach where you are suggesting that we get to. So I'm going to move on to our last portion of the panel, which is something that many of our attendees had asked for, which is action recommendations. Some of you have given action recommendations already through the course of our conversation. But just being respectful of everyone's time as we come to a close, I'm going to ask Felicia and then Dr. Shorter the same question. And maybe we've sort of addressed this, but what do you think providers need to do on an individual level to engender trust in Black patients? Felicia.
Listen. Listen and ask questions and never assume. Don't assume that that the individual, that the patient knows exactly what they need, or that they're asking the questions that they need to ask, because a lot of times we don't know. When I was pregnant with my first child, I did not know the questions to ask. I was told, blood pressure is a little high. Okay, what does that mean? Don't assume that we know. I mean, I may know that something's wrong with my body, but I may not know. I'm not the doctor, you are. So don't make those assumptions. Ask the questions. Don't wait for me to ask questions, and have a conversation with me. Don't rush me out the door. Don't just look at my chart and make assumptions. Talk to me. Ask all the questions you can to get the information, and start that dialogue so that we can build a relationship, and so that we can then start to build trust with each other, so that I'm more comfortable sharing with you. I don't want to feel judged. I want to be, I want to be vulnerable and open with you as my primary care physician or my doctor, so that you can provide the best treatment to me. So you also want to come in open. Yeah, you have to do those things.
Dr. Shorter.
Thank you, Felicia. That was said perfectly. That is definitely something that we as providers should challenge ourselves with every day, with every patient encounter. Just because you think about it before one session doesn't mean that it's going to, again, be on your mind the next day. So literally, it's something I feel like you have to make sure that you do with each and every patient. I also feel like actually listening, actively listening is key. So not just passively listening, but participating in that conversation, us asking questions that we might not understand, and really kind of getting to the depth of what makes up who this person is sitting in front of me. And I think challenging myself to prove to myself, essentially, why am I recommending a certain treatment? Why am I feeling a certain way? Why am I becoming frustrated maybe with whatever is happening in that room? And really just, just constantly challenging myself to make sure that I am providing care that is appropriate for my patient, and also based off of the new complexities that they have provided to the conversation. And like you said, just knowing what is going on in their social situation, and knowing how to be creative, or at least look up the answer and get back to them about some creative ways that we can help make sure that they get access and to the same type of healthcare another patient might be able to get easier.
Thank you, Dr. Shorter. For Marianne and Jennifer, I'll also ask each of you the same question. In 1 minute, what policy changes should we be supporting that promote health for Black families? Marianne, I'll ask you to go next.
Sure. I would say the Momnibus 2021 Act, and that is linked in the chat. There's a bill of 12. There's an act of 12 bills, and it's pretty comprehensive, and it's a good start. And it is going to be hopefully passed. It didn't make it last time. So I encourage us to all become familiar with it, to support it, to talk about it, and understand how it impacts our lives. So that's the first thing that I would suggest. I'd also say get involved. I echo what Dr. Shorter and Felicia said. Information. I'm going to start with I'm going to end with where I started. Inform yourself. There's so many tools out there. Call your senator. Call me. I am happy to answer your question. There are many people at MCC that would be really supportive, because that's where it starts with making change, is knowledge and knowing what's available, and trust yourself. I can tell you, we know what our bodies need. We know what we need. So trust yourself and get informed.
Thank you, Marianne. Jennifer?
Two things. We have, I believe, a sickness system in our healthcare system, and not a health system. And I think that needs to change. We spend more money per capita, and we spend more money as a percentage of GDP on healthcare in this country than any other country in the world. And by the way, than many countries combined. And we are at the bottom of the list in terms of equity. And so we need to reorient our healthcare system. Our healthcare system has some underlying values, I believe, that are obstacles to moving towards health equity. So I think we need to have much more of a systematic review. That's number one. Number two, we need to invest more in public health. And that is where I believe public health, and then moving beyond public health to the social determinants of health. It's a category we use as social scientists, but really what it means is, the environment in which people live, work, are born and die. And so we need to focus on that, and we need to have a different kind of an orientation, which is towards trying to create the conditions for people to be healthy and make healthy choices. Felicia's right. Not everybody can go to Whole Foods. Not everybody can go, have stable housing. People, are losing their job. There's all sorts of things that are going on. And if we start orienting ourselves, look, we can transfer data through the air from, my desk at my home to, my partners in collaboration and research in South Korea, Taiwan, and Germany. We need to start using the innovation and entrepreneurial orientation that is the good thing that results from, a lot of the conditions that we set together towards public health. And public health in itself has more of a and the last thing I want to say is we need more of a social justice orientation to these areas of our lives. And if we orient that as our North Star, we can use this ingenuity and the innovation, I think, in a much more effective way for equity and health.
Thank you, Jennifer. There's a question in the Q&A about the policy information that Marianne mentioned, and it is actually in the chat. And I think, Diane, will you be sending out links as well? Mm-hmm.
Yes.
Okay.
Yes.
So with that, I'm gonna close. Thank you so much to the panelists for your time, for your expertise, and for your brilliance, for sharing your stories. This was really important and really humbling to hear from all of you. Dan.
Yes. So I just want to thank all of you. Sarita, thank you for being the moderator. I think providing these, you hopefully you all heard these different perspectives, and there are things you can take action now. I just want to reiterate, knowledge is the currency of freedom. Thank you, Marianne. We can arm ourselves with knowledge. We have power. Trust ourselves. So there's lots of resources through this chat box. We're going to distribute those after it. We also have them on our website. I also believe an asset is building communities of peers that actually can help you. So, Dr. Shorter talked about how do we do that more with Black and Brown doctors and helping them mentor each other. So start doing that work. You don't have to wait. You can start doing that work. And I think, for white folks out there, we have to do the work on deconstructing racism that we have internalized. Whether you think you haven't or haven't, we have internalized it, and that falls on us. So whether you're a white provider or just a white citizen, whatever, we are taking this work very seriously at Women's Way. It's not just doing implicit bias training, it's really learning how to be live an anti-racist life, both individually and as an organization. And I'm going to share a resource. There's a great resource called Seeing White. It's a podcast. And it really dives deeply into the history of white people in this country and where the whole construct of white and Black began and why it began and who constructed it and how it has infiltrated every system in America. So I asked you to learn about that. I request that folks learn about that as well. So there's lots to do. Don't stop these conversations. Reach out to folks like myself and Marianne. We're here. We want to help move our region to a more equitable and just society. And frankly, women are the backbone of our society. They're the backbone of our families. We have to elevate all women. So thank you all again. Our next one will be in April on access to affordable housing, which is again all related to this. So Be safe, be well, and thank you again for spending this time with us. So good night, everyone.
Thank you. It was a pleasure.
Thank you.
Thanks,
Bye-bye.
Sarita.
You.
Thank you all.
Thank
were
you,
awesome.
everyone.